This is Brennan Hodge, and I am the founder and CEO of Citizen Health, and this is our second episode of Rebuilding Healthcare. And today's topic is the power of physicians. Now, if you're new to what this series is, let me fill you in a little bit. Like the title says, Rebuilding Healthcare, that's exactly what we're doing. We're bringing people to the table, patients, physicians, caregivers, other medical professionals, and we're asking you what you want and what you need in a new healthcare system. And then we're coming together to build it together. And it's going to be open sourced for all Americans to see, all Americans to participate in. And this is going to be a plan that we put together and craft some solutions for our problems in America. So on that note, I am going to turn it over to Dr. Ernie Sussman now, and he's going to give a recap on what happened last month with our first episode. So Dr. Ernie, the floor is yours.
Thank you, Brennan. So like Brennan said, we had our first meeting on February 2nd after I reached out to him a month or so prior, expressing my frustration. He was nice enough to host the meeting. This is our esteemed panel. So our first speaker was Dr. Dahlia Wax, who's a Nevada general practitioner. She's a radio syndicated talk show host, iHeartRadio. She talked about freestanding ERs, basically likening them to roach motels run by big business, where you can kind of get trapped in there, and if you need a higher level of care or you need a specialist, they may not always be readily available. They're not really ERs. She talked about network status as a big issue, leaving patients with huge bills if they go in there. Sometimes they'll be told that they're in their network and they're not. Recently, efforts to ban surprise billings or out-of-network patients are gaining steam on Capitol Hill with potential areas for bipartisan compromise, and that's a good sign. And also, these freestanding ERs are competing with real ERs for qualified staff, and as you know, sometimes that's hard to find. Sometimes these freestanding ERs have staff that are not so qualified. They may have more than their share of new grads. Well, that's me. I'm a Nevada private practice urologist. I talked about conflicts of interest, where our elected officials are taking money from healthcare insurance companies. And we talked about a website called opensecrets.org where you can see who took what from both houses of Congress. We talked about networks and how it's so crazy that the out-of-pocket expenses and percentages almost double when you see an out-of-network provider. Now, to make matters worse, these insurance companies, and there's only a few of them, are going EPO, exclusive provider organization. Their networks are becoming even more narrow, and now there's no out-of-network benefits. We introduced the McCarran-Ferguson Act, which has been around since 1945, which basically provides antitrust exemption for the healthcare insurance companies. They basically can sit down and talk and set rates, and we talked about how their premiums and all the numbers seem to be pretty much the same. Now, it passed the House easily in 2017, and it was at the Senate level where it was introduced in December 2018 by Steve Daines in Montana, and it may be, as Kim Corbis said, in the Judiciary Committee now. Well, how do we get to the next level? Do we go federally? Do we go to the state level? All that was introduced during our meeting. Do we use our medical specialty societies to garner support? And one of the reasons that I reached out to Brennan, and also one of the highlights of my talk, was we have multiple advocacy groups, and some are on the call today. Doctors for patients, patients for doctors, doctors for patients for doctors, and we're all basically pulling oars in the same direction. So why don't we consolidate? Why don't we put our efforts together? And then I talked about recruiting our patients. They're the ones that vote. And they're the ones that are sitting across from us in the exam room, and we have their undivided attention. So why don't we talk to them? And we provided examples of how the voting public can make a difference. They're our patients, and they really want what's best for them, and they want what's best for us so we can take care of them. David Balot was kind enough to join our talk. He's a former, he said, recovering Texas hospital administrator. One of his points was we really don't have a free market-based healthcare delivery system, and he provided examples of that. He discussed the 1332 waiver to the ACA Act, which allows for certain health expense accounts where the money goes to the patients as opposed to a health savings account. He is the director of Right On Healthcare and also Healthcare Policy Director in Texas Public Policy Foundation, and those are his Twitter feeds. He also talked about the AMA, and I think a lot of us know this, that it's really the old guard. I mean, I know a lot, maybe some of you are members, but do they really represent us well in Washington? David Ballat advocates for a new AMA, basically a coalition of physicians who want real change. And Kim Korba, who's a general practitioner in Pennsylvania, she's a direct primary care doctor. She basically, and you know more about this than I do, but she opted out of all insurances. She has a membership-based model. She claims to the DPC slashes costs of primary care for unlimited access to her and to their doctors. There are no copays, no deductibles. She provides direct dispensing of drugs with minimal markup. And she talked about, I put in the 3 A's, even though she didn't present it that way, but it makes sense. And this is what's so great about direct primary care is access, affordability, and attention with small patient panels. And she has a call me first philosophy to avoid trips to the ERs, which will save everybody money and also get the patient taken care of quicker. And she also pointed out that we are, as physicians, one of the only trade organizations who don't dictate what we charge. And the famous Brian Dixon, MD, Texas psychiatrist who has a fee-for-service billing model based on time. And Brian, please correct me if any of these are inaccurate. And he advocates letting patients purchase care directly through their physician. He discussed about tax-exempt status for certain institutions, incentivizing them to provide health care, then giving them tax breaks. More recently, in one of my urology emails that I just received this weekend, breaking news, bullet point number 4, is Senator Chuck Grassley is now probing whether the hospitals are really using these tax-exempt status laws favorably, and he's getting the IRS involved and so forth and so on, and maybe Brian can look into that or this group can look into that. And then he also discussed, instead of hospitals at $1,000 per night, he talked about, medical hospitality centers, basically a glorified, Hampton Inn or what have you. I just threw this in there. I'm just a small business. It's just myself. I'm in solo practice. And my Aetna PPO plan is coming up for renewal in April. And now I don't even have a PPO anymore. Now it's an EPO. So I cannot even see a doctor outside of Nevada. My daughter's going off to college in Arizona next year. And I don't expect you to read this, and I'm not going to read this, but this is what I got from my insurance broker. And so you don't have to read this, but this is how complicated healthcare insurance plans have become. And you'll love the next slide. Now, we're all physicians. I mean, most of us probably all did well in math, but if you can figure this one out and tell me what the best plan is, and you know what you're going to need next November and how it's going to be best for you financially, let me know offline, because this is how crazy these health insurances have become. I don't know what, you can see the point of my slide here. Well, I saw this on the internet the other day, a picture of these fine young folks from whatever they call themselves. And this is the Green New Deal protest at Mitch McConnell's office in the Senate. And the point of my slide is, what are we doing? What are we doing that these folks are doing? What are we not doing that these folks are doing? What can we be doing better? Why aren't we taking the fight to them, like these folks, whether you believe in what they're preaching or not? And that's basically my summary. All right, I'm sorry, I have one last slide. This tweet was on yesterday from Mar Alexander, Senator from Tennessee. And he's been out there with healthcare reform. And he basically put himself out there and said, if you have any ideas, you can see the second paragraph. You can email him, and it's at the bottom, the email link, if you have any ideas, lower healthcare costs at help.senate.gov. And one of my slides in the original presentation, showed a way you can contact your congressman, and we all know how to do that, but I think we should make avenues available to our patients and let them start screaming and shouting at them instead of screaming and shouting at us every day about their out-of-pocket.
Good recap, and thank you for that. Now we'll just hop right into this. And since we have an excellent group of panelists today, it's not going to be best for me to introduce everybody with all these acronyms everybody has after their names and all these organizations. So I'm just going to lead into a list that I have here, and I'm going to allow you to introduce yourself and talk about who you are, what your organization is, and what your organization is trying to do. And then we can just go around the table. And I have a list here starting with Dr. Marilyn Singleton.
Okay, hi.
Hey.
I'm hello from California, so I'm still having my morning coffee, but thank you for having this program. I'm the president of the Association of American Physicians and Surgeons. Now, AAPS started back in 1943 when the first single payer bill came out, and it was a way to get private practitioners together and say, wait a minute, we're not going to get rid of the independent practice of medicine. So over the years, just bit by bit, whether it's been through physician and pulling in patients for advocacy or starting lawsuits, that we've been able to change some things. Back in the 90s, we were able, well, and even before then, we sued for physician price caps that were started back in the late 70s and won that, and various other lawsuits on some of the restrictive rules in Medicare, and then sued to make Hillary Clinton's secret meetings unsecret, and won that big time. So all the Clinton care stuff had to come out, and learned some very, very important things about how the government manipulates healthcare. So that's one of the things we do, but the core of everything is that it should always be for the patient, bottom line, and that's the motto, all for the patient. And it's trying to keep all of us practicing medicine with the highest standards. And there's so many things that are included in that, and that you're right, we have to fight, and we have to be the ones to do it. And going to the patients is what's very important. It's one of the reasons we have a full patient tab where we tell patients how they can opt out of Medicare if they want to, despite the restrictive Medicare laws, how they can get involved in some of our letter writing campaigns. And every time the government asks for comments, just like what was put up on the screen, that we have a model letter or encourage people to write their own and send these in, because it does work. There have been several times that the Federal Register has actually mentioned the specific comments, the organization's name, and said, because of these comments, this rule, ... whatever it was that we were commenting about. And so it does matter. And it is important to get the patients involved, because let's face it, most people really don't care what happens to doctors. Hillary Clinton made sure of that in the 90s, of painting doctors as greedy pigs feeding at the trough of human misery. Clearly, that's not what we are. But once you have this picture painted, then it's like, well, who cares if they get paid? Who cares what their hours are? Who cares if they're burning out? Obviously, it does matter, because a happy doctor is a good doctor, and it matters to patients. And we do have to get the patients involved and make sure whatever we do has some sliver in it where it makes it clear that this is why it's good for patients, not that it's just good for doctors. Dude. I could go on for 3 hours, but move on.
I love it. I love it. So yeah, just sent out a list for the order. So I don't know if everybody saw that, but kind of move on to Dr. Marion Mass.
Thank you so much, Brennan. I'm Dr. Marion Mass. I'm a pediatrician in the Philadelphia area. Westby Fisher and I founded Practicing Physicians of America at the beginning of 2017. And we're an organization that is speaking for patients by allowing physicians to practice as they were trained. It's as simple as that. Let us fulfill our Hippocratic Oath. Our two big specific missions right now are pushing back on the maintenance of certification, and there's certainly a lot happening about that we can discuss in detail if needed. And we have become very involved in the battle to repeal legalized kickbacks. I know Dr. Singleton is on this as well. Christina Lang's group PWT is helping. Others are. Brian Dixon knows all about it, Dr. Dixon, but to repeal the legalized kickbacks enjoyed by the companies in the pharmaceutical supply and hospital supply chain that are providing little value. No R&D, no manufacturing, no distribution even. They're just writing contracts and collecting kickbacks, costing America $200 billion plus per year. The government gave them the kickbacks. It's time for the government to get rid of them. So this is going to be one of the hallmarks that is going to come up in April. We can discuss April in a moment. I'm really, really glad, Dr. Sussman, that you brought up Lamar Alexander's request. Just yesterday, several of us, including David Balot, who was on your previous webinar, and C.L. Gray of Physicians for Reform, and I got together and we crafted a response to Senator Alexander. We delivered it yesterday. We have about 14 asks within the document. It was authored by a bunch of us, including Chris Held from AAPS, including Kim Korba, who is an independent consultant and expert and pioneer in DPC care, and including some other authors. We can get into that at some point. In any case, this paper that we sent off to Senator Alexander is the basis of a seminar that we are holding in April 1st at the Jefferson building of the Library of Congress in the members room. I went to Congressman Roger Marshall and gave him the idea of responding to Senator Alexander and then taking the response and using that as an opportunity for us to come together on these roughly 14 ideas that have transpartisan appeal that will lower costs and reduce waste in the healthcare system. It's really quite exciting. Honestly, at this point, I'd like to invite the whole world, but it will be shared on multiple social media platforms live. I've got I don't want to show you my desk. Like, you can't see the desktop, but that's good. I've got little pieces of paper everywhere. There's only a space for 100 in that room. And the room is it's like the Palace at Versailles. It's just going to be such an incredible event. I know members of PWT were invited, members of AAPS were invited. I really feel bad about this. Citizens Health is on the list. So in other words, multiple physician organizations are coming. Patient advocacy groups are coming. Lawmakers will be coming to a breakfast the following day. Lawmaker aides will be invited. We can talk more about what's on the agenda later on in the call, but that's going to be one of the big events that's put together by David Balot and Dr. C.L. Gray from North Carolina, Physicians for Reform and Practicing Physicians of America. So that's what we have on the docket for the spring.
Thank you. And I wrote some notes. I want to hear about those 14 ideas later on. And okay, so Dr. Ryan Neuhofel.
Yeah, I'm Ryan, and first and foremost, I'm a family physician in Kansas, Lawrence, Kansas, to be precise, Rock Chalk Jayhawk. I started a direct primary care practice in 2011 when it was barely a thing, if a thing at all. There was a handful of other family physicians around the country who had adopted the practice model, but I think there was only maybe 2 or 3 who were actually using the phrase direct primary care, and so I kind of reached somewhat of an existential crisis, I think, early in my education and training, and had decided that the system was broke in many ways for doctors and definitely for patients. And so decided to kind of build a field of dreams of sort with my own clinic in 2011. And in that time, kind of focused mostly on my own community and trying to build my own practice and a sustainable business. The direct primary care movement kind of naturally grew around me, and those connections of friends and colleagues supporting each other, just kind of gained steam throughout the years. And in late 2017, a group of about 50 direct primary care doctors had been discussing forming an organization to kind of support other DPC doctors in a more kind of cohesive way with nuts and bolts of starting practices and growing practices and advocating for the model. And so in January of 2018, those 50 founding members founded the Direct Primary Care Alliance. I think we officially launched in January of 2018. Last year was a year of building the structure of the organization, which I'm sure, as many of the people on the phone call know here, is not easy. I think we're the only organization that's solely dedicated to direct primary care and is entirely led by volunteer physicians. So that was definitely a big task last year, and we did a great job. And we more kind of formally launched this January. We now have 350 members, and our members are all practicing direct primary care physicians. The Alliance mission is pretty broad in some sense, but firstly, our focus is on helping physicians, whether that be through mentorship, learning about the details of starting a direct primary care practice, growing one, the various facets involved with that, providing a repository of educational materials, and there's lots of this available to some degree in various locations, but we kind of wanted to make our organization a one-stop shop for best practices. We do have some component of advocacy, probably not as much as some of the other organizations mentioned here, because again, we're really focused on the physicians and helping them with the day-to-day decisions and grind of being a business owner and being an entrepreneur. And we recognize all these other huge, giant things happening in Washington, D.C. and all those legislative things that are so important. And so, we try to pay attention to those things and issue some statements, but we don't want to be distracted by those things. I think a lot of people in the DPC community, they're just struggling day to day to open a business, to be a successful business owner. And so it's just overwhelming, I think, to a lot of physicians in the trenches to pay attention to all of these, details about a bill coming up. And so, we very much appreciate the other organizations doing that, and are happy to partner with them and chime in when we think it's helpful. But I think our mission going forward is going to be more of a kind of a speakeasy for DPC doctors. Someone described it, a place where we can feel comfortable talking to each other. And we don't all have the exact same ideas about everything. We don't all use the same technology. We don't all use the exact same business practices, but it's a place for us to come together and bounce ideas off of each other. And we hope that as the direct primary care movement grows, that we can be viewed as a leader in that.
Awesome. Thank you, Ryan. And thanks for being the pioneer. I know all the pioneers usually get the arrows in their back first. So,
I've had so many at this point that I don't feel them anymore.
All right. Well, I appreciate that. Now, next is Brian Dixon.
Alrighty, y'all. Thanks for having me back, Brennan. In this time around, in my capacity as the Physicians Rise guy. So one of the funny things that every doctor knows is that you don't shock asystole. So asystole is that flat line thing when, anytime you see a medical drama and they're flatlining, and you always see them charge the pads and they chew, right? And all doctors laugh because we know that that's not how it works. But when you think about it, that's how we are publicly perceived. So the perception of medicine is not how we know it to be. And so I bring that up because when we go out as physicians and we're trying to change the narrative of who we are and what we do, we're working against some kind of preconceived notions. We're working against some stuff that just is frankly wrong. And so as physicians, we've been kind of known as the people who like to make a whole bunch of money and kind of lord over the patient decision-making process. And so to make a long story short, to change that narrative is going to take a concerted effort. And so when it comes to all the different stuff going on, whether it's PBM, whether it's MOC, whether it's insurances, intrusion on the practice of medicine, all that stuff, speaking with one voice is really, really hard. And so, and I know Christina and Marion it's kind of like we're in a code situation. And anytime you're in a CPR resuscitation code situation, you want to have not only all hands on deck, but each person has their in a code situation, each person has their own role. So you have your person at the head of the bed, you have your person putting in your IV, you have your person putting on the leads, blah, 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 do your chest impressions, so on and so forth. And so to try to bring a central rallying cry to all the different positions, that's where Physicians Rise basically came from. So Physicians Rise isn't an actual group, it's not a company. It's more of a rallying cry, a central idea that we can rally behind that then supports all the individual groups. But what I've learned in business is that in order to get an effective marketing campaign, in order to get an effective idea out there, you have to have a whole bunch of money and a whole bunch of infrastructure, just like Ryan was talking about. Like, even if you're going to start a supportive group for other doctors, you have to have that admin support, and that takes a whole bunch of money. And so Physicians Rise was first kind of like a hashtag, let's rally together. Now that we're like a year into this whole kind of social experiment, it's time to ramp it up. And so we'll be looking at other options, and I can talk about that later, to make it more into a marketing for the entire profession of medicine. But yeah, I just always want to be clear, it's not its own standalone thing per se. It's more of a call to action for each person, especially each physician. And then there's kind of two parts, which we're going to concentrate on physicians right now. And then later on, we'll concentrate on marketing directly, basically to patients, to let them know that their doctor appreciates them. We wouldn't be here without them, that they are our reason for being. But first, we want to get the troops together so that we can basically go to war, because that's what's happening in the political landscape of medicine.
Awesome. Thank you, Brian. That's something that needs to happen, is the marketing message needs to be unified, because that's what I've seen is you got a bunch of different fragmented objectives. We're all trying to do the same thing, but we're wasting our efforts doing it differently. So definitely thank you for putting this organization together and this movement. Nice hashtag too. I like that. All right. And now Christina Lang.
Hi guys. Thanks for having me on the panel. You guys are super inspiring. So people like you are actually the reason that I got involved with Physicians Working Together. Physicians Working Together was founded in 2015 by Dr. Kim Jackson. And the point of the organization is really to be a sounding board, a billboard, where all the different advocacy groups can come and let everyone know what they're doing. I'm a new physician. Well, not anymore, I guess. I've been out of residency for 4 years now. But being relatively new in practice, I don't know all the ins and outs of healthcare. There's a lot I have to learn. There's a lot of ideas floating around from attendings, or prior attendings and current colleagues on how to fix healthcare. Everyone has an opinion. And what we all do agree on, though, is that we need to work together to make things happen. And that's where Kim's group, Physicians Working Together, comes in. Since I've joined the past 2 years, Physicians Working Together has led National Physicians Week, which actually Dr. Marion Mass was also involved with establishing. It's been changed from 1 day to a week. And a lot of physicians say, what is it? Who cares? It's just more time. But it is change. It's actual change that is happening. And physicians are starting to feel more appreciated because of these small things. Last year, we hosted an online conference. This year, we're sponsoring something targeted towards medical students. We feel that medical students are the future of medicine and want them to also feel supported. We're all burned out. Let's start from the very get-go and get them feeling like we have their backs. It's an umbrella organization that allows for sharing of information, of advocacy. So multiple groups share their events on the Physicians Working Together page on Facebook and also on our website. So if you want to get involved, please check out our website and our Facebook page and see where you can fit in. I mean, we all have different schedules, different levels of involvement, and that waxes and wanes throughout the year. And this allows for a place where you can go and see what's the next thing going on, who's doing what bill, who's going to be in DC when, who's fighting, where and what front. The MOC stuff that Marion is helping sponsor, that's on there as well, so that you can get involved and help support this efforts, because we all have to basically work together. Another thing that Physicians Working Together does is town halls. So we we try to sponsor town halls in various parts of the country so that you can be there in real time. I mean, we all love this technology and be able to like have these conferences, but there's something to be said about being met in person and inspiring each other in the same town and working towards similar goals. So I think the last thing I want to say about physicians working together is that right now we have the campaign again for the students for National Physicians Week, and Doc Jackson's also going to start spearheading a campaign to raise some funds for the organization. It is a nonprofit organization, and she will be outlining what these funds are for. But as everyone knows, in order to make things happen, it costs money. And one of the projects that they are working on is PR. She's met with approximately 7 different PR firms. And it's been an interesting ride to hear what they're presenting and their ideas of how they want to represent physicians. But we really want to get feedback from our members, which our group is actually now about 9,000 members strong, and we want to get their feedback on how they want to be represented in the media, how they want to approach the patients, and how they want to be seen. So yeah, it's been a great organization to be involved in, and I hope that this inspires some of you to maybe come check us out and join up and see what's out there.
Awesome. Thank you, Christina.
Okay. This, and it's available online, is a letter to Lamar Alexander. So what Marion was talking about, his asking for various recommendations. And if anybody's welcome to come online, modify the letter, do whatever you want. And there it is there for people to see, and just go to the website. And can also go and learn more about, we've had a lawsuit against the American Board of Medical Specialties. It's gone on now for about 3 years with multiple hearings and whatnot, and being able to keep it in the courts, and is still moving along. You know, the wheels of justice move very slowly, but you can click on here on the website and see the pleadings and see what's going on, and all sorts of stuff that's going on in that direction. So in any event, there's a lot of pre-written letters that you can find on different topics. And so it's very useful, because not too many physicians have time to sit down and go from scratch and write one of these things. And so it's always a big help to at least have a template, and then you can move on and, you know, say whatever you want, but at least it gives the template for starting one of these letters. So anyway, this is under testimony and comments to government agencies.
So if you guys can see this, this is the Physicians on Fire. And this is actually also sponsored by PPA, Practicing Physicians of America. Shout out to Marion Mass. And so this is what we're doing for National Physicians Week this year. We raised funds, about $1,000, and as more donations come in, we're hoping to have another $1,000 cash prize, so that there'll be multiple prizes. And the idea is that we want medical students and residents to put together a video celebrating being a physician. So this speaks to what Dr. Dixon was saying about PR. We need some positive things out there, and this is a way that we're going to get some positive images of physicians, you know, enjoying their career choice, basically, out there. So they can sign up on this page, and we want them to share with all their med schools, the alma mater, you know, their residencies, everything. And then here's a little snapshot of the different sponsors. So again, PPA, PWT, OpenX. And when you click on these, they actually go to the sponsors website. So here's PPP, PPA, and then OpenX Med. And that's also another sponsor, a prime sponsor for the event. So yeah, make sure to share this with any medical students or residents that you know. We need to get the word out there, because this is a very easy way to start changing the script that's out there right now.
Interesting. This is the first time I've heard of this.
Yeah. It's a great cause, you know. It's a really fun thing, and a good way to get involved. I mean, it's so easy just to like take a little a snapshot and the link, and just text it to people or email it. It takes 5 minutes, you know, because we all know we're all very busy.
Last year at our annual meeting, we had picked up something that had gone on for probably 30 years and then sort of went by the wayside in the 90s was a student essay contest. So we revitalized it last year and had an amazing turnout. The students really are interested. And we gave them a choice of 2 questions, and we had tons of students submit. And, you know, we had a cash prize and a free trip to the meeting and all that. And Christina is so right. It's all in the students. And we partnered with Benjamin Rush Institute, which I really encourage everyone to go to the website, get to know Beth Haynes, who started this whole thing. And it's directed at students. And Benjamin Rush chapters are student run. So the only downside is sometimes when the student president graduates, then the chapter just can disappear. But for the most part, the chapters have kept going. And it's very important because a lot of the medical schools do not really allow outside folks to come in, and certainly people that might have a different point of view than that medical school is proposing. So it's very, very important to one-on-one engage with the folks. Just at our last Dallas meeting we had that helps teach people how to be DPC and other third-party free practices, we had some students who just happened by it surfing the net, and it was great because we were able to hook up a resident who came. She was from Michigan, and I had just met a fellow who was from Michigan who was a DPC doctor, and she was feeling discouraged, like, oh, can I really do that out of residency? And she met this fellow who said, yes, you can do it. And it was so exciting to see the residents not be depressed, because so many times they are, and feel like all they hear is bad news about what their future holds. So
Benjamin Rush has been awesome. They also sent it through their emails to their constituents so that they've helped spread the word. But to speak about the residents and the medical students, you know, I've been also volunteering with OpenX, and I've been inspired watching the different residents and medical students involved with that project. They're from everywhere, from Stanford University Northwest. We have a student leader from Columbia University, and the students really are the future of medicine, and they're the ones that are going to really, well, they're going to take care of us for one thing, and they're going to be the ones to lead the direction of the country, right? And to see them wanting to get involved. I remember as a medical student, I could barely keep up with just the exams, right? You know, our schedules, but they take time out of their day to get involved. They just need to know what's out there and how to do it, and they're willing to do it.
that's right. Thank you.
Mm-hmm.
Interesting. You said you're a contributor to OpenX Med. It's the first time I've heard about them too.
Yeah, it's a platform that is basically taking on technology and information. They want to democratize medical information. So unlike UpToDate spending, you know, $500 a year, and it's written by PhDs, OpenX wants physicians to write protocols based on their experiences in everyday practice. So real clinical protocols for other physicians to use. I mean, it's kind of the idea of having a physician's lounge online and sharing, like, so Marion's a pediatrician and she knows like how to treat neonatal jaundice like the back of her hand. She barely even has to look it up, you know, but then a medical student wants to know what's the best way, step by step, how to do it when they're on rotation. They can access that information from Marion. Or if it's something more complicated, like you're a doctor in the middle of West Virginia and you don't have the ability to get subspecialty care available, like at your fingertips, this allows for that. This allows also a conversation to occur between specialists and primary care, because we really believe that primary care is the building block of all of medicine. And if we can empower primary care physicians, then we can fix all of medicine. If they do a better job treating their patients, they feel more supported, they have information at their fingertips on what to do next, rather than constantly referring out, it kind of gets out the traffic jam, if you will, of medicine that's occurring right now. So they want to leverage technology in a way that we really can use. Unlike a lot of the things out there right now, a lot of the EMR, as you guys can all, you know, you can speak to, the horrors of it all. You know, a lot of times technology comes in and it's not actually beneficial. It makes more work. And the idea of OpenX is we want to hear from physicians exactly what they need in real time.
That's amazing. I love that idea. I would like to.
And the students have been so involved. Like, they're the ones helping garner, bringing in their attendings to write topics. And they're the ones kind of really making it their own.
I like that a lot. I'm going to have to dig into that a little more, and maybe you can introduce me to somebody, because that's interesting stuff. I want to jump off that and ask you, Ryan, what Christina just said as far as primary care physicians needing help from a specialist. What does that standard protocol look like now? I know there's a couple of different organizations out there you can reach out to, but just in your everyday practice, what do you experience?
Yeah, I think first and foremost, you know, having a better environment to practice primary care in allows you to practice a much deeper and broader scope of care. And I think that's probably one of the saddest things that's happened to primary care is over the last generation and even recent decades. You know, the very concept of primary care has been so eroded and devalued, certainly in the minds of patients themselves, in what they expect of their physician, what they think we're capable of. But even amongst our colleagues, you know, and I think there's probably some regionality to that, with you know, the coasts probably thinking primary care is lesser than the Midwest or the South. But even in the Midwest here, you know, patients who are under the age of 50 kind of don't view their primary care as a real doctor who can provide real medical care for real complicated, serious problems. They kind of make a lot of presumptions that we must refer anything out that's not a Z-Pak. And so, you know, I think that the first thing that allowing physicians the opportunity and the environment to fulfill their actual training and knowledge and experience is vitally important. And then, you know, there always is a time, and this is true for primary care or a specialist, where there's going to be an end of the road to your knowledge, experience, and skills. And that's where, you know, specialty care or ancillary type care, you know, whether that be a cardiologist or a dentist or physical therapy, you know, that's where that comes in. And I think the job of primary care is to find the best resources for that patient. Number one is get them great medical care, but also hopefully be cognizant of how much it costs the patient. And without the time to develop those and be aware of those resources, you know, in a regular primary care setting with 7 to 10 minutes for visits, that's just an impossible task to do. So, you know, there's really not a lot of thought even in the referral process, frankly. You know, I think physicians are kind of guilty of saying things to their patients that, you know, oh, I know, you know, Dr. Jones is the best doctor in town and will take great care of you. And even though they don't really know if that's true, it's just kind of where they know. And they have no idea of what anything may cost the patient. And so I think in the direct primary care model, or any primary care model that allows us more time with patients, we can develop those resources better locally for our patients. And sometimes online. You know, I think there's a lot of platforms and services out there. I'd never heard of OpenXMed, but that sounds another very interesting resource where if we had the time, we could read up, we could curbside, we could probably take care of a higher level. But then, you know, ultimately it comes down to that patient and their choice. So I all the time will say, look, here's 2 or 3 different options in our area to do an MRI or to see a cardiology group. And here's kind of the pros and cons of each of those, and let them make a decision, you know, to really enable the patient to make that decision. But if you don't have that information to give them, you're kind of just, I sent you a referral in and that's it. So I think, you know, that relationship between the patient and physician is a lot stronger whenever we can actually sit down and talk with them about what their options are and the pros and cons of each of them.
Sure.
I'll tell you along those lines, something that's very important to me. I go to a direct practice, and in the days where patients will get sick, they're just a body on a slab to the people who see them in the ER, and then they're taken care of by a hospitalist. Some of the decisions that the patient might really want to make, particularly at end of life, are not known to these strangers in the hospital. And one of the things that my practice focuses on is they will take care of you in the hospital. they will be there if you go to the hospital. And it's very important to me. And a lot of the patients, because they just feel like they're just seeing strangers.
Mm-hmm.
And what you're saying about just that personalized connection, and we all know personal connections are about 90% of healing. And it makes the patient feel so much better and so much more confident in medicine, and that doctors are doctors and not automatons and not robots. And I just really appreciate what you're doing, because I know how valuable it is to me as a person.
Yeah, I think the policy wonk world has this so dead wrong, and they look at these kind of small little quote incentives or disincentives to force doctors to practice better or quality medicine. And on some large economic scale that can definitely be true. So it's not that money doesn't matter, but at the small individual level of a physician and a patient sitting in a room together, I think that relationship and that environment in which those discussions are had are trump any type of small financial thing. And I think that's where a lot of people just miss that, and even the very nature of trust in doctors, not just in primary care, but more broadly, has been undermined. And if, you want to lament, some of the kind of snake oil or kind of unscientific things that patients buy into that frustrate physicians, I think the primary reason for that is because, in general, patients are looking for somebody to trust, and they don't know what's scientific or not. Even my patients who are relatively educated, I could explain things and throw a bunch of terminology at them and convince them of almost anything. But what they really are looking for is somebody to trust in a relationship. And if someone's selling them snake oil, but they sit there and listen to them and hold their hands, they're going to believe that over a physician who may be much more qualified to help them in that area. So doctors can, complain and moan about that type of stuff all day long, but unless we fix our own profession and give patients a real relationship and a real connection, we're never going to fix that problem.
Well, physicians are looking for somebody to trust too. And it gets back to what you said about building and bringing physician groups together. Mm-hmm. Unfortunately, a lot of our legacy medical organizations have conflicts of interest, and they can't avoid it. They're tied to the insurance companies, they're tied to big pharma, they're tied to the hospital groups. And, the meeting that I mentioned happening April 1st, and the authors that were on that paper, we don't have any conflicts of interest. And lots of people on this phone call, Marilyn, you've joined me, Brian, you've joined me, Christina, you've joined me, Ryan, I've met you down there too. We go to Washington, D.C., we don't have conflicts of interest. We're there to speak for our patients and on behalf of our profession, fulfilling our oath. Who's America going to trust? Because right now we have this corporate politico complex. Someone brought up Open Secrets. I'm all over them, man. They are fantastic. And it's just really fun. Like click, click, click. I just sent off another publication. I'm on the editorial board of my Bucks County suburban Philadelphia newspaper. Of course I am, because, I kind of can't help it. It's another free job that I do, another volunteer job. But I just sent them another blistering, juicy piece about the Senate hearing panels on the drug costs and who was tied to who and who's collecting money. And you know what? It's not one side of the aisle. It's both. We all know that. And the patients are going to have to decide, do we trust these big corporations that are not touching the patient and who offer so little value in the system? Or do we trust the person who's coming into the exam room? And by the way, for us as physicians, what an almost embarrassment for us to have to go into that exam room, face our patients, and tell them, we can't give you what you need. We're so sorry, we want you to be on drug X, but it's not on the formulary, which, the PBM is taking the kickback to decide what goes on the formulary. We're so sorry, we want you to have that CAT scan, but we can't get it approved through your third-party payer. We're so sorry. We know you have a huge hospital bill. We can't help that. We might be the hospital employee, but we're making 8 cents on the healthcare dollar, we the physician, and even though we did all this training, we can't help you. That's where I think we've all finally come together. You know what? If we banded together, we could help them. And it gets back to what you said about us involving the patients. So at some point later, I do want someone else to speak, but at some point later, I want to talk about a video that just this morning we put out there. It's a YouTube video working with with an advocacy organization for the over 50 crowd.
And Marion, to piggyback on that, so that's one of the reasons, a slight segue or tangent, is I love how wonderful the physicians have been in volunteering their time. In order to scale, it all comes down to money. And and I put it in the chat, but one of the things the APA is so good at is they already have an infrastructure. They have people who, are constantly sending out those email reminders of pay your dues, even though, again, I'm not a dues paying member. But it takes money to get all this stuff done. And so I wish there was a really good way of getting more people enthusiastic about investing in their doctor, like Ryan. I'm DPC, as in direct psychiatric care. And I have a business coach. I had to have a come to Jesus meeting with myself to basically say, I can't run everything by myself. And when I sat down with my business coach, he said, you have to put money into marketing, and then you need to basically contract that out because you don't have time to do it anyway. And as a result, then I'm able to continue to run my business so that I can do the healthcare, to deliver healthcare. And I would say that in scaling our marketing message or trying to get our to combine our powers or something, we need to have some kind of mechanism to show people that money isn't a bad thing, especially if it's money and getting the message out, because then all of our groups could then benefit from that same pool of money. I don't know how to do that, but yeah.
Trust is such a big issue. Even the thing that we're doing with the $1,000 scholarship, you wouldn't believe how distrustful people are. We're giving money away. We're giving $1,000. There's no strings. There's nothing that you have to do, and yet people still are like, wait a minute, what's going on, right? And it's all up front. We're completely transparent. But trust, we have to get physicians to trust each other. I mean, even physicians working together is trying to raise a little bit of money. And sorry, that's my mom trying to grab something because she has to go. Physicians working together is trying to raise a little bit of money as well. And it's the only way to get things done. Right now, everything's coming out of Dr. Jackson's pocket and all these PR firms that she's meeting with. It costs money to get someone just to organize the emails and send out things, and we're kind of our own downfall, right? We have to trust each other, help support each other. Otherwise, that's how pharma gets in. That's how all these big corporations come in. They have lots of money. They come in and they throw their money around, right? And then people are wondering, why didn't you get supported by your, people you trust? Well, they're not willing to do it,
I have a question, if I may, for Marion. What is the name of that meeting or group that's having the April 1st meeting in Washington?
Oh, the conference is called the Free to Care Conference, and it is co-hosted by Practicing Physicians of America, David Balot of Right On Healthcare at Texas Public Policy Foundation, and C.L. Gray of Physicians for Reform. And we were the big underlying sponsor at the congressional level is Congressman Roger Marshall, who's an obstetrician from Ryan's state of Kansas. And Roger and I have worked together for 2 years. He's very supportive. We're, all of us that did this conference were absolutely dead set that all of these ideas are going to have transpartisan appeal. And we have a Tuesday legislator attendee breakfast. And there's a little more room open in that event. I mean, not much. I mean, we have spaces for 100 on Monday and spaces for, I think, 150 on Tuesday. And the legislator breakfast, we're inviting from both sides of the aisle. And Congressman Marshall's actually anxious to find a Democratic member of Congress that wants to co-host the breakfast. And we've sent out some requests for that.
I have another question too, regarding this group here and, our initial meeting, and the, David Balotz and Kim Corby, she was on the call earlier today. But these are all great organizations, and we talk about coming together. So aside from these town halls that hopefully I'm sure we'll have another one if Brendan has his way, and I'm sure the way I think we're getting some momentum here. In Facebook, we have in urology, there's this hotshot in Phoenix who has a closed group called the Thriving Urology Practice. And my question is, these are all great people, great organizations. Can we do something? And I love that open MX or whatever that's called.
Open XMed.
XMed. I want to comment on that in a second. But getting back to Facebook, they have these closed groups where it's just, you have to be invitation only. And my question to Brendan and the panel here is, can we do something like that with this core group and the other people who were on the first meeting and other people who are liking our comments on Twitter and want to be involved? Can we form a closed group on Facebook or another platform so we're not, after this call, we just don't all go back into our corners? Because these are all great people, great organizations, and doing great things, and a lot doing the same thing. Can we form something like that? Does anybody have any suggestions?
David,
You guys should.
I do.
Oh, I'm so sorry.
Yeah. No, we actually already have something similar to this. And for background, people that don't know, Citizen Health, we are a public benefit open source organization of like grassroots people just like us trying to rebuild healthcare. Everything we're doing is transparent and open for everybody to collaborate on. So we already have something very similar to what you're suggesting. And it's kind of like a Facebook group, but better. It's called, I sent the link, it's hq.citizenhealth.io. And we got about probably 85 people, launched it a couple months ago. And it's exactly that. It's just where people can come and collaborate together. And there's a whole lot more, it's more powerful than what you see. We can have different groups, different types of memberships. You really do a lot with it, but I'll pose that as a place for everybody to go to follow up after these particular town hall meetings.
You send invitations out to us, and so we have an idea at 2 a.m. or a weekend, and we can all share it with each other, and then
Please do.
hopefully keep these town halls going. Maybe whatever, but this way we can consolidate our efforts and we're all kind of pulling the oars in the same direction.
Yeah, definitely. And you can post any thoughts, any things that you guys are working on the PWT site. We have 9,000 physicians across the U.S. and they're all active in varying degrees, but it's good to get the word out, right? So any of these town halls or anything that you want people to attend, please feel free to post that on PWT because that's the point of it.
And I think Twitter, more people are using Twitter anymore and put people's handle in Twitter and post these things, and they really do spread. And then you get new followers after, they see one person has retweeted X article you wrote or whatever it happens to be. And that really spreads quite fast and gets a lot of views.
I'm getting away from Dr. Sussman's original question, but there's a group called Doctors on Social Media that was spawned by Dr. Donna Coriel.
I was just going to say her too.
Yeah, it's spelled Dana, but you say Donna. And she's got, I don't even know how many thousand on there. And they had to teach me how to tweet because I wasn't much of a twit. And when I first went on Twitter, I published something about repealing the safe harbor for the GPOs and PBMs. And within an hour, I was booted off of Twitter. I had to make a new account. No kidding. I felt like, wow, I must be hitting a nerve.
That's a bad line right there.
Yeah, but so many docs, like tagging so many docs gets the stuff out there. And there's, for instance, recently there was some issues around the vaccine issues, and so many docs did a phenomenal job of covering some physicians who were getting beat up for advocating, good reasons to get vaccines, and not enforcing, but it really, so many docs is fantastic. Donna does a fantastic job. Another great person to add. And then back to your original question, Dr. Sussman. David Bolott and I have had this discussion. There's still kinks to be worked out. He's a former hospital administrator. He has said to me many times, physicians have to lead this. It needs to be physician groups. There needs to be a landing pad where all of the groups can remain independent and autonomous, just as physicians should be able to, but then a place where they can all come and, when there's something that comes up like maintenance of certification or supporting pure DPC or repealing the safe harbor or getting behind the medical students in, National Physician Week, what can we all agree on? Hey guys, here's what's going on. Let's get this information out there. But it would be a I guess, a landing pad. He's got some funders that are very interested in helping to put that together.
Yeah, and Physicians Working Together is trying to help fill that void as well, right? So that's what their goal is to be a billboard, so that we're nonpartisan. We don't advocate one or another, but it's a place where everyone can put what they're working on, ask each other for ideas, ask each other for help.
Yeah.
And so watching the networking occur, I mean, with Dana and Marion and all the various groups, they're able to post what they're doing.
Yeah, so I'm a Trekkie, and one of the best analogies I use for what I see happening is you can't have multiple captains on a ship. So if you put Captain Kirk and Janeway and Cisco and Picard, and if you put them all on one ship, they're all wonderful in their own right. They all have their own shticks, and that's a really bad idea. However, you can have them as part of Starfleet, meaning every captain has their ship, and we're all working towards one goal. And and I know I just nerded out on a Saturday morning, but
Nerd alert.
Yeah. So I'm really excited to be a part of a Starfleet of awesomeness. So, y'all.
Yeah.
Love your analogies, Brian.
I wanted to get back to, again, if there's any consensus that people on this webinar have a place to get together amongst ourselves and share what's going on in your individual organizations. Because I can't check 8 different sites.
Right.
Not even on a weekly or basis. We all are busy. After we leave this call, we're all going to do, real things. And so can we, if you agree, maybe you're saying, I'm too much of a renegade, but can we agree to maybe form a group of the leaders of these different organizations that are represented today, and some of the other ones that are out there, like SOMI Docs and the other ones that were mentioned by Marion? Can we agree to maybe coalesce those into a chat or a private group, either via Brennan or a Facebook separate group page? Something. Can anybody agree on that, or does anybody not want to agree on that?
No, sure. That sounds like a great idea, but that's exactly what Physicians Working Together is.
Again, you're going back into your group. What I'm saying is,
but it's not a group. It's an umbrella group, so it allows for everyone to kind of work together.
Right, but we all want to work together, but how do we get? You guys are all thought leaders and leaders in your groups and leaders, and we're all doing similar same thing. I'm saying, can we get the folks on this call and some of the other ones that are out there who are not on this call in a closed group, like Brennan suggested, or something? And if anybody else has any other suggestions? Now, if everybody says we're going to go with, your organization as our meeting place, I'm fine with that. I just want to know there's one central area that these people like you guys and like-minded people who are leaders in advocacy groups have a place to get together, even if it's 10 o'clock at night.
Are you suggesting like a forum just for dozens of people, or just anyone within our organizations?
Just like the leaders of your different organizations. I'm not talking about
like a smaller group.
I'm not talking about your rank and file. I'm talking about people on this call, the thought leaders, the David Balats, the AAPS folks, and Christina's folks. And a place just for the upper brass to get together and share stuff with each other. And then you can say, hey, Christina can get on one night and say, hey, look at this. It just came on our website, or this doctor from so-and-so has this idea, and I think everybody should get on board with this. As opposed to me having to go on 8 different websites.
Yeah. Christina, I don't know how your guys' actual forums work or whatever you want to call them, but you guys have a place like that where you could create like a smaller group for organizational leadership people and keep it close to that?
It's very easy to do, and anyone can organize like a small Facebook group that just has organizational leaders in it, and then we can have it so that it segues so that when there are larger announcements that we need to make to a larger audience, it's easy to get that on that board. So yeah, definitely.
Yeah, I think that's
a great idea, Dr. Sussman. That way we can have an unfiltered conversation.
Because I don't know.
Yeah, I think that's part of the problem is, you get like hundreds of people or certainly thousands, and the conversations go in so many different directions. Yeah. So there's some great private Facebook groups out there, but for like direct primary care, there's one that has, I don't even know, it's like 2,000 supposed doctors on there. And it's a great resource, I guess, in some respects, but in other respects, it gets so overwhelming. There's too much information. So even when you get everyone on the same platform or same group, you just can't filter what's on there every day. So I think if there were like a more of a select group of organizational leaders that we could go and chat with each other about important things, that might be helpful.
And I think recognizing everyone's particular strengths, each group's particular strengths. For instance, AAPS, wow, you guys knock it out of the ballpark in terms of policy, you know, and like when the bill comes out, you all get into it, dig into it, and I can't do that once I understand it a little better, or it takes me a long, long time to do it. I think you're all pro at it. I'd love a course on that. And I'll get to an AAPS meeting, maybe September, I'm hoping. It's in California, I know. You know, at PPA, we have a number of writers, and we've been getting out to the lay press. If you look on, Brian, if you could share the PPA's 2018 accomplishments page. We had things published last year from our 6 board members, the Wall Street Journal, the Washington Times, the Washington Examiner, the Hill, multiple things. There was over a dozen publications. And I think what are we good at? We're good at that, plus connecting with the lawmakers. And then there's people within different groups that have great connections with the lawmakers. And, you know, like Christina, you've mentioned the work that you're doing with getting videos ready. And that's a whole different layer that other than working with patient advocacy groups we haven't been involved in. Benjamin Rush, they're fantastic at connecting with the medical students. Why does one group need to do that when they're doing it? It's just if we're all connected together, and it just goes on and on in terms of different layers of what everyone's doing. And then there's going to be some crossovers, like if you did Venn diagrams. You know, we do a ton with maintenance of certification, so does AAPS, so does NOMOC, and PWT has really amplified that message. That was just phenomenal. So I think discovering like who's got strengths in what and who's expert in what, and having that all put together, wow, huge.
Yeah, I think if we could get some type of forum, you know, with maybe 1 to 3 max leaders of an organization in a smaller group, you know, I'm presuming less than 10 organizations total here. That might be a way to kind of stay more on top of things and figure out, you know, collaborative opportunities. But I don't know the best, you know, forum or technology to do that.
And I'll make the offer that on April 1st, we can work on Skyping. We are like full to capacity in that room right now. And I have people like lined up waiting. It's very exciting. The second, as I mentioned, we have a little bit more space. It's a 7:30 to 9:30 2-hour breakfast. So probably it's going to be people in the DC area that want to come to that, but we can Skype people in on April 1st. It's going to be shared. We could host after the breakfast the next morning, or even Monday evening might be hard, but we could host a meeting right afterwards while we're all fresh, because there's going to be a lot of leaders from, you know, different patient and physician advocacy groups present in that room on April 1st. It's really something.
Why don't we do another, I mean, Saturday, during the week, I guess we're all busy, but can we do another Saturday as a follow-up to your meeting in Washington, Marion?
Delighted.
Maybe our third forum can be a follow-up to this meeting in Washington with whoever wants to jump on that. I don't know if Saturday is good for you guys.
That actually would be perfect. I'm a good recap of everything. I'm open for that.
I had to think about what that next Saturday is, but like at some point I also have a family vacation in April at my husband's insistence. I'm sure he'll throw my phone into the Atlantic Ocean.
Speaking of family, I have to actually get off this call, unfortunately. But Dr. Sussman, you had another question that you had mentioned you wanted to ask or pose?
Oh, the last thing I was commenting on the OpenX. I think that was an excellent idea for the consultations. And I think a lot of money can be saved and a lot more transparency if there are specialists that primary care can reach out to, and fast track testing and save patients money and know where pricing is in the different facilities. I think that's great. I got to look into that. I've never seen that.
Yeah, I mean, to speak to urology, an easy algorithm that would be like Foley troubleshooting. How many calls do you get from a hospice about Foley's at night at 11 p.m. at night, and they didn't do the basics, right? And you're just like scratching your head like, oh my gosh, that's exactly what that's for.
I mean, that if that was the go-to, instead of filling out a referral form, patients will be taken care of better. Their disease may not progress. It may cut down in costs, especially with patients paying most of it because of their high deductibles. You could save so much money. I see so many patients who get a free and a total PSA as their initial screening.
Freak out, right?
Like, why? That's a lot of money. And then
I know.
bill, right? And it's just one example of these poor people get hit with these bills, probably 30% of which are unnecessary. So I think I have to look at that.
Yeah, exactly.
Thank you for coming on this morning. It was very,
having me, you guys.
Yeah, thank you, Christina. I appreciate it.
Super inspirational. And please reach out if you guys have any further questions or want to do any further collaborations. It was great meeting all of you.
Thank you. Thank you. Bye-bye.
Bye.
Yeah.
Bye, Christina.
Hey, I want to follow up with the discussion about forum systems and an online place that we can come together and collaborate. I've tested out probably the top 10 or 15 forum softwares out there. Discourse, I can go on down the list. They all fail in some way. I've come across something. It's actually, if you remember Ning, one of the first social networks before Facebook, the founder of that one came out and created something called Mighty Networks. It's kind of like a alternative to Facebook groups and LinkedIn groups. And we set one up for Citizen Health. And if you're seeing my screen now, that's what I mentioned, that link with hq.Citizen Health. It's awesome. I mean, it's like you can post news, topics, videos, photos, anything. It can be cultivated to your particular preferences, whatever you want to follow, what topics you want to follow. We got probably about 90 members now. I just looked at it. And people have bios, you can have topics, you can post events, and also getting down to the groups. This is something I started around Christmas time, but we can start groups, as that's what we're referring to, is start a group where we can come together and invite other people and follow up with these discussions happening here. And I'm also thinking about if we can create a bot where any time one of your organizations post a blog update or tweets, we can just repost that here, just to keep that activity going all in one centralized location. So that's just a thought. I mean, this is like I said, I've tested everything out, and as far as a community building platform, this is definitely the best.
But Brennan, I completely agree with you. So when you take the 30,000 foot view, and if I asked each of you where you get your news, if we produce something as a coalition, it needs to be as engaging as where you get your current news. So for example, I read the New York Times every morning, and I pay $15 a month to get that on my phone. I do the NPR app, which is free. I get some news from Twitter, take it with a grain of salt. And my standard for getting my attention is super high. So the content quality has to be high. It has to be kind of pretty well vetted. I would say, not to throw water on anything, I would say that because I am kind of busy and I'm running a practice and I have bills to pay, I can't add another let's kind of meet and chit chat kind of thing. It has to be very focused. It has to be very goal oriented. And I would say that if we're going to have content, or if we can create content, I'd say that a lot of doctors are probably the same. And so of course we need money to build that infrastructure, but I would say I'm totally willing to have a conversation offline where, some of the organizational heads get together and we say, hey, let's create cold content. So if you've ever heard of The Skim, I think they do it great. It's two journalists who got together and said, there's too much news out there and we don't know where to look, and it's not well collated, or it's not well culled. And so they do it, and their subscriber list is through the roof because they make content and they cull content that works for their people. So I would say, I don't know if Citizen Health can be that funnel for us, but and I'm willing to pay for it if it's good content.
Yeah, I will say that we're going in that direction. We're here to elevate your voice, and the voices of physicians, the voices of patients and caregivers, really everybody that participates in healthcare and every single day. So any way that we can help foster the growth of the right things, we're going to do. I mean, that's what we've been doing. And it's hard building a community. I mean, everybody on this call knows it's just really hard to build a group of people coming together around something. And then it's even harder probably is to get the groups of people that are trying to do things to come together and form one group.
One word, meow.
Yeah, like herding cats. Yeah. But you know, it's going to take numbers of people to do this. And also what I'm thinking, you know, we're talking about marketing costs money. Yes, it does. But at the same time, we have a lot of people that feel the same way about healthcare. So we can harness all of those people, all of our social media accounts. And if we have the same message, I mean, that's essentially free marketing. And we can piggyback off each other, share tweets, share blog posts. If we have the same unified message, then you know, we can reach a lot of people and have a lot of influence without spending a dollar. It would take coordinated efforts for sure, but it is possible since we do have a large number of people. And I'm kind of curious. So everybody on this call, how many people do we represent? As far as I know, Ryan, you said about 350 members.
I think say about like that.
9,000. So I'm kind of just curious. What about Marion?
When we take all of our followers from PPA, all of the members, all of the followers of Physicians Rise, which we spawned, I think we come up to close to 4,000. But when, and David Balat and I have talked about this with the Library of Congress meeting, the people represented in that room, we're going to have an excess of 30,000 physicians represented by the leaders that are in that room. So.
And we have 4,000 or 5,000 paying members and about 35,000 on the email list and that's patients as well as physicians.
Yeah. And Physicians Rise has about 800 people on its subscription list and growing a little bit every day.
Wow. So
notice I'm not saying anything. I have access to, I think I'm the only surgical specialist on this call, but I have access to our clinical arm of urology, American Association of Clinical Urologists, and I'm the state representative from Nevada that we meet annually. I'm pretty well connected. It's a pretty tight group. So, you know, from a surgical specialist standpoint, which feeds into all this because money is money. We cannot, you know, in urology, we don't have too many patients on a routine chronic care basis like primary care, psychiatry, what have you. But we're more of a treat, aside from the oncology patients, we're a treat and street specialty, along with maybe some other surgical specialists. But I have the ear of a lot of these doctors, and we have a really tight network. And some of the things that I presented in my synopsis recap earlier, I grabbed just from an email that I got from our organization the other day. So
all in all, I'm seeing, probably at max, 40 to 50,000 physicians that we would have influence over or could influence. Still, that's a drop in the bucket when you think about everybody out there. And I'm pretty sure that just about everybody in healthcare feels about the same way. The question is, how do we get 10 times as many people?
It's the secondary reach, I think. So you have all those leaders, they're all in groups. Those groups represent X many thousand. Like, a lot of that happens because of places like Twitter and Facebook and whatever, all those things that my teenagers won't let me on, Instagram, blah, blah. I think it's the secondary reach because there's a whole nother world of people like your retired doctors who are enormously valuable that are not on Facebook, that are not on Twitter. Maybe they're on Sermo, Lord knows where they are. And there's like people that are just under their rock trying to get through their everyday. And if you could convince them, hey, here AAPS has this wonderful site, go to this place. They've made it so easy to be able to comment about DPC and how to enhance DPC's reach. So go here and do that. And it'll take you 5 minutes. If you can get to that secondary round, that's how you're going to amplify and increase the numbers, I think, personally.
What if we just created a new social network that connected all the physicians and all the patients? Because I know you mentioned Sermo, and I think, to my knowledge, you got Sermo, you got Doximity for physicians, and that's about it, right? as far
But,
as
you know, if we create this central organization, then we can reach out to all of our contacts on duximetry and all these other places. And I think that by itself, we may start, that'll be the glue to slowly, it could take 3 months, it could take 3 years to bring people together while still maintaining your own organizations. So,
I think it also depends. Like, I think if physicians get a win, you know, like if something happens that's big, you know, for instance, Marilyn, you guys have been working on a lawsuit on MOC. You know, there's another lawsuit that got filed that PPA crowdfunded the investigation. It's a separate lawsuit that got filed in Philadelphia in December on maintenance of certification to the ABIM. It's just been expanded, includes now RICO charges. So whatever you call those treble damages, I'm not a legal person, but one of those things, if there's a win, then I think physicians are going to be like, holy smokes, we can really do something. Poof. You know,
well, one of the things, and there's also two sets of radiologists that are suing the American Board of Radiology. So there's lots of these MOC things that are now starting to swirl out there. I mean, the wheels of justice are slow. Our lawsuit is now almost 4 years old, but you know, the court does what it does. But we've had some big wins, and really a huge win, and it's something that applies to only physicians. This is something that doesn't relate to patients at all. 2 big wins with warrantless searches of doctors' offices, and we do try to publicize that and let doctors know that if the DEA comes knocking on your door, you don't have to necessarily let them in unless they do have a warrant, and the same with the medical board, which they're starting to do now because of the opiate crisis, that they just come into doctors' offices without a warrant and they take a lot of patient information that's private. And we had helped a doctor win a big case on that. And the other huge thing is sham peer review that's getting more and more common now that the hospitals are buying up the smaller practices. And one of the ways to get rid of people who don't want to buy into the hospital or sell to the hospital is to then kind of get charges by the medical executive committee to try to get them off staff. There was a huge case of that in Texas, probably last year. Brian, you may have seen it. It was a surgeon who did robotics, and the court found that him getting kicked off the staff was motivated by economic means and had nothing to do with his competence. And they've done the same thing to an ophthalmologist that had a different kind of technique, and the other guys didn't use it, so they tried to get rid of him. So this stuff is going on, and we had about a couple of years ago, it was a very big win in that the judge actually adopted the term sham peer review. So now it's become a legal term of art. And this is something that's, again, it's a physician thing and not something that patients can get onto. But as far as getting physicians to want to get involved, because it's tough. I mean, it's like even right now, here it is, I do have to go feed my dogs, that doctors don't have, they're yapping outside the door, that don't have a lot of time. But like you say, you get a win and you can point to this and say, hey, if you have this problem, here's a place to call, here's some people who can help you. Because a lot of times by the time people come to us, it's almost too late. You know, they're desperate and have gone through all these problems on their own. And that's where Sermo is interesting, because it really is sort of a bitch session for doctors. And I think doctors feel like they need that, and a place where you could tell the truth about what's going on in your work life. But that's a tough thing. It's a tough thing to admit our failures or problems, and we all want to look like we're hot stuff. And so it's hard to get people to do that.
You know, so talking about Sermo, what exactly is Sermo? I've never seen the interface.
Well, you can't unless you're a doctor.
Yeah. What is it? Is it like a social? I mean,
It's a blog thing, and somebody will put up a question, and in order to join on to it, you have to give your medical license. So again, so that's how it can be a bitch session for doctors, because they have to know you're a doctor, because people say some stuff that you wouldn't want a patient to hear, talking about patients who lie and, things that we all know happen, but you're not going to want patients to know that you kind of talk about them that way.
I believe it was started after the ACA passed, correct? Or was it before?
No, it's been around before that.
Oh, I didn't know that, because it just seems that there's always a lot of that ACA talk on there, but
no, lots of other
oh
stuff.
no, there definitely is lots of other stuff, but it's
it's been around
for a long time.
Long time.
Yeah,
and the physicians that are on it are not, they use like little pseudonyms on there.
Right.
Sometimes some people use their real name. I don't know any psychiatrists that use the real name, because sometimes they say something, a patient came in and nobody wants to be identified as giving away patient information. Obviously nobody uses patients' names, and sometimes people will present a case and say, I have a teenager who's a drug addict, do I tell the parents? I mean, real questions that people come up with in their practice. But again, it's certainly a doctor thing, and which is totally different, I think, from what you're looking for.
I would agree, because Sermo is very inward looking, so looking inward as a profession, whereas, we need a almost like an advocacy marketing force, for lack of a better term. I don't know what other term to use, but yeah.
Well, that's what Kim Corbin and I talked about, like not just inward, but she was very excited to hear that there's patient advocacy groups coming on April 1st as well. And she's going to be the person one of the people that's going to be discussing innovative models of healthcare delivery and financing. So
I just have a comment to Marion in Washington, and your agenda's full, but just two things that kind of burn in me. And one is that McCarran-Ferguson Act that gives the healthcare companies, free rein to set prices and talk to each other.
mm-hmm.
Maybe you can find out where it's at in the Senate. And again, I mentioned Steve Daines. He introduced it in December. And apparently when we were on the last talk, Kim Corbett was looking it up while we were talking and said it's in the lapse of the Judiciary Committee. And Dave Ballard said, because it passed the House in 2017, like 400 and something to 7 or whatever it was. And so he thought, well, if there's that much support bipartisan, he was wondering where this was to try and repeal this. And the second thing is, just as a general comment, I think half the problem is our CPT and ICD-10 codes are way too complicated, way too long. And I think this is kind of off topic a little bit, but I think that's half the problem. There's just too many items on the menu. And getting back, we're here to try and get rid of insurance. I think half the problem is the whole thing has been set up, but because of the government, it's too complicated. There's too much.
Could I actually, I wouldn't say I'm here to get rid of insurance. I'm here to get rid of third-party intrusion. Because if we get rid of insurance and we're dealing with the government, we've just swapped one taskmaster for another.
Right.
And the reason that insurance has prospered is because of the government, we all know that, right? I'm glad you brought up the codes. I believe it was Jane Orient of AAPS who uncovered the fact that the codes, the CPT system royalties, were given to the AMA as a backdoor deal, correct? Is that correct, Marilyn?
That's correct.
Yes, and it's very interesting because those very same CPT codes that exploded under ICD-10, they're now managed by the PBM, the middlemen, Optum, because Optum are also data collectors. There's been a deal between the AMA and Optum and between the government and Optum. I just might have someone who used to work at Optum coming and talking on a panel when we talk about the PBMs. Isn't that just grand? In any case, so there's Optum getting to administrate these codes, publish them, the AMA making, $111 million a year, more than twice as much that they make off of memberships from these CPT codes. And these CPT codes are what drives the whole healthcare IT infrastructure, because we all know the EHR was made to get paid, like, or not get paid really. And so I agree with you on simplifying, but if we make it about let's simplify the codes instead of let's remove the middlemen for the equation. I mean, I like what Ryan's doing with his model better. Why does the government or the insurance company need to be involved with every healthcare interaction? Get out of my exam room.
Correct. I'm 200% in agreement with everything you said.
We can go ahead and start wrapping it up now. This is
Sounds good.
about an hour and a half is what we try to stick with. So yeah, I appreciate everybody being on today and your time and your information, your knowledge, everything. I mean, it's going to take everybody coming together to fix this. If anybody else has anything to add or comment, go ahead. If not, we can go ahead and end it. Everybody good?
I guess all I'd say is that I think we have a door of opportunity that's like cracking open for us. And I think we need to hold hands and kickbox that door down together.
I'm with you on that. It's the momentum. We got to keep it going day in, day out. Because right now, I mean, you know, this upcoming election, that's going to be some deciding factors in the next 4 to 8 to 12 years of healthcare. So, I mean, we've got a good opportunity right now to change some things, to put some things into place that can help us out later. So
maybe we can set something up in April.
Definitely. We can definitely do something in April. And then the other last thing I'll say is it's already discussion about Library of Congress, fabulous. When are we going to do this again? Next year, bigger room. The worst thing of this has been, and it's just a nightmare. It is and it's not. It's an embarrassment of riches. Citizens Health, by the way, is on that list. You know, so if enough people say, "Oh, we can't come," Citizens Health will have a spot. So I'd love to have one of you represented there. You all can decide who your best representation is. And I'll talk with you about all of the specific events that are happening, the legislative breakfast, you know, what we have planned. I have a small little army of people that have cocooned around to really help with all of this. And we're very excited. The paper is not quite unveiled that we sent to Lamar Alexander. The paper will be public at that event as well. There's 2 more issues to add before the April thing, and then that thing will go out. And it's all about cost and waste reduction and bipartisan issues across the aisle. So, yeah.
Perfect. Well, anything you want us to share out and put in the social media universe, let us know, and we'll just retweet and build off that.
Okay. So I think I put it up there, the YouTube video about the safe harbor. So we just got that this morning. I worked with Association of Mature American Citizens. It's a 1.6 million member advocacy group. They're definitely conservative leaning. There's no disguising that. But if there's a liberal leaning group that speaks for patients, I'm happy to go and get filmed by them, and we'll share it out to all their members. I'd love you to share that video. The Black Healthcare Coalition was involved. It's a group of pastors from across the country that are just torqued about the cost of insulin, the cost of healthcare in general, and they see how their congregations are being affected. Wow, these guys are riled up, and I just kind of feed them a little more information and get them more rabid. So I'd love you to share that, and then I will publicly be putting something out there, probably like maybe tomorrow or Monday, about the Library of Congress meeting, just so that people are aware it's happening.
Great effort.
Will do.
All right. Fabulous, gentlemen. So proud of everything everyone's doing.
All right, everyone. Thank you once again for your time today, and until next time.
Thank you.
Thank you.